Therefore, would be great to see how Terumo can help us with this technology for the future and to have stabilizers that can be applied endoscopically. We're going to go forward with the next phase of the meeting. Each track will now continue on to the next master sessions. The cardiac track will go into the Cardiac Masters Session 3B, which is again atrial fibrillation and revascularization. It will be moderated by Dr. Niv Ad and Dr. Nicholas Dahl. The thoracic track will go on to the Thoracic Master Session 3B. This one is outside the OR, how to make a difference. It will be moderated by Dr. Mara Antonov and Marcin Zielinski. We're going to let the moderators take it away now, and we'll see you back here shortly. Enjoy the session. Thank you.
Thank you, Bob. It's my pleasure to be here with my good friend Nico Dahl. And I'm Nivad of White Oak Medical Center and the University of Maryland in Baltimore. And I welcome you to the Cardiac Master Session 3B, atrial fibrillation and revascularization. I'm joined here by one of world's greatest and good friend, Nico Dahl, that is now in the north of Germany in the Heart Center at Bad Rottenapfeiler. I hope I'm saying it right, Nico. If not, you can correct me. Dr. Dahl, would you please tell the audience we have in store for them?
Yeah, thank you very much, Niv. It's a great pleasure and honor for me to share this session with you. We're going to get started with one of Live in the Box presentations. Then we do have 2 invited lectures, and at the end, an abstract presentation followed by a group discussion. And we really would like to encourage you participation, and please use the question answer window to the right of your screen to ask your questions as we go along. Our first presentation is a Live in a Box presentation and is titled Convergent Endocardial and Epicardial Ablation for Atrial Fibrillation, to be presented by Michael, a good friend of mine, Zembala, and Piotr Buchta, who are very well-known AF surgeons from the Center of Heart Disease from Zabrze in Poland. So, dear doctors, the screen is yours.
So, good morning, ladies and gentlemen. Welcome to Poland, to Zabrze, to Silesian Center for Heart Diseases. We're here with Professor Suwalski. Piotr is here with us. Ola is a scrub nurse. Tomasz is the echo cardiologist, and Jurek is the anesthesiologist. From echo, we know that the long axis of the neck is 2.5 centimeters, and the short axis is 1.2. Let's measure the base of the left atrial appendage. All right, so we're ready to insert the clip, and the clip goes through, again, 12 millimeter port. So once inside the chest, the clip is open, and now you can use these levers to manipulate the clip inside the chest. So it is really helpful because it allows you to minimize manipulation of the left atrial appendage.
Okay, so first we try to
put it on. So it's sneaked in pretty nicely. We'll now take a look from the bottom if we have the whole neck. Is the closure complete? The appendage is closed.
Mm-hmm.
And we can see the whole appendage.
Mm-hmm. I don't see much of a stump, actually. It looks like a smooth alignment.
Looks good.
Yeah, so I'm very happy with the closure. So Michael, if you agree, I would then just release the system.
And this is one of the greatest addition to the second generation. Look at the ease, how easily you can remove the clip from the site. Remember, the first generation had that big frame that was quite difficult to remove afterwards, but this is smooth and easy. So excision or coagulation of the ligament of Marshall can be performed either before or after that procedure, after clipping. We've decided to do it afterwards. Okay, so the ligament of Marshall is completely cut off. So we're ready to close that site and move on to a second stage. To centimeters from the subxiphoid. We'll just make it seal. Okay, so we are inside the abdominal cavity. You can see the liver. Okay, in this stage, we open the pericardium. So we're continuing with the incision. Okay, this is good enough. And look at the length of the incision. It's nearly the size of the grasper, like almost 1.5. So it is really small. And now we're ready to move with the cannula. The cannula is inserted in the abdominal cavity. And now using just gentle manipulation of the cannula and the camera, a combination of the two, we're inside the pericardium. IVC can be visualized here. And this is the left pulmonary vein seen from below. You can see how changed that is from previous procedure. So we now move towards the right pulmonary veins, and again, look at the scars created by our colleagues electrophysiologists here. Per position, meaning we'll apply energy to the posterior left atrium. Okay, suction on, water on, and we go. Energy applied to the tissue is once again 30 watts, 90 seconds. We will flush or fill the pericardium with saline just to protect surrounding structures from any thermal damage. The temperature probe is very near the ablating electrode. The temperature is 36.0. It is a nice constant application of energy. Okay, sign off, off. So we are now closing to the, we're in close proximity of the right pulmonary veins, and we apply suction. See how the tissue is being sucked to the device, and we start the energy. Okay, so we've just finished the ablation of the posterior left atrium, and as you can see here, the whole area has been severely ablated. We'll test it tomorrow with using their Carto guidance, but it looks like we have a whole area covered down to the level of coronary sinus. We'll just put a small drain and leave it for 1 day, and that's it.
My name is Piotr Buchta. With me, the table is Dr. Krzysztof Myrda. We will perform the second stage of the hybrid ablation of our patient. We start with the mapping. With height output pacing, we will check the exit and entrance blocks. Okay, and we confirm also the block going around the pulmonary veins and across the posterior wall with height output pacing to once again confirm the exit block on the line. As you can see very nicely on the Carto screen, in this patient he's 1 day after the surgical part of the hybrid ablation, where the pulmonary veins are almost isolated. There's only one spot. And look what happened on the Bruca screen, intracardial recordings, is silence with these ectopic beats, as we have observed from the beginning of the procedure. So you can see there's no capture anymore, also in the right superior pulmonary vein. Okay, so beneath the roof line, we don't have any capture. And as the ectopic beats has disappeared, I will suggest to try to induce any other tachycardias. Okay? As we can see now, the patient is non-inducible anymore. Don't have anything more to do there. So it was perfectly performed by the cardiac surgeons. We are very happy with that. There is no other substrate to modify. The cavotricuspidal isthmus is still blocked, and the pulmonary vein is isolated. As we can see, there is still no single additional beats what we have observed at the beginning of the procedure. So, we're ready.
Piotr, thank you very much for your cooperation. It was a nice example of how two professionals, different specialties, work together for the good of a difficult patient. So thank you very much.
Thank you.
And once again,
Greetings from Zabrze.
Greetings from Zabrze. Thank you.
Yeah. So thank you, Dr. Zimbella and Buta. Our next presentation will be presented by another very good friend, Dr. Amiram Revashvili from Moscow. He's from the Vyshinsky Institute of Surgery in Moscow, Russia. The title of the presentation is How I Treat Atrial Fibrillation, Perspective of a Surgeon who is also an electrophysiologist. Amiram, please take it away.
Distinguished co-chair, dear colleagues, it is an honor for me to take part in ISMICS 2021 online conference. I'm sincerely grateful to President of ISMICS, Piotr Suwalski, for the kind invitation. The purpose of my report is to present clinical and my personal experience in treating atrial fibrillation. Here we can see the evolution of surgery, clinical electrocardiophysiciology, thoracoscopical and surgical arrhythmology. My journey started in 1980 with a silly operation, epicardial mapping, operation with bypass, catheter ablation of different type of tachyarrhythmias using thoracoscopical and robotic technology, and treating patients with atrial fibrillation with concomitant heart pathology. Today, I would like to briefly cover such core issues as mechanism of atrial fibrillation, catheter ablation, surgery, and hybrid approach. 2008, we started using surface mapping method and identified a rotor, the different side of left atrium and right atrium, ablate them, and we have only 10% of success rate. So today, nowadays, we know that the key mechanism of atrial fibrillation is triggering PV sleeve, macro-reentrant drivers, neurons. And macro-reentrant mechanism is well explored on perfused heart and recipient's patient with optical mapping by Vadim Fyodorov. You'll see here three-dimensional rotor in right atrium, diameter of this micro-reentry circuit is 10-15 millimeters. What about catheter ablation? According to ECC and EACTS guidelines for treatment of atrial fibrillation 2020, if patient failed drug therapy, we should propose him to perform catheter ablation like first line therapy, class 1 and class 2A indication. Unfortunately, following study showed that RF effectiveness like Creo to number 40-50% for paroxysmal atrial fibrillation, long-term follow-up. For the long-standing persistent atrial fibrillation, success rate is less of 20%. Even robotic technology, Hansen, stereotaxis are not able to dramatically alter treatment results. Atrial ablation as POV, or pulmonary vein, is a method of choice today, but the case condition for gap formation still remain by behavioral occurrences. What about surgery? In 2087, Cox suggested MACE-3. The effectiveness was more than 90%. Damiano first published his data about bipolar radiofrequency ablation for the MACE-4 with effectiveness of 90%, 92% in first year follow-up and close to 74% of 10 years follow-up. It's important to create full block in posterior lobe for left atrium, silent area, and you can improve the long-term results from the 33 to 66%. NIF8 and Jen Cox introduced mini-MACE, Creo-MACE procedure for treatment of long-standing persistent atrial fibrillation. And you will see here incision diameter and Creo probe here. And results was very, very impressive. And 90% after 1 year and close to 80% after 5-year follow-up. In our approach for MACE, we'll present by Professor Popov lately, but I would like to conclude For MACE-5 modified procedure, we use only bipolar ablation technology, left and right sided, for bilateral approach. We use a prostate and right superior, right inferior PV. We make superior and inferior line, bipolar and cyclic ablation around the pulmonary vein, amputation of left atrial appendage. Second step is during CPB in normothermic bypass. We can control the sinus rhythm restoration and can map of the left and right atrium. So I would like to say, so results is don't show any hospital mortality, 2% of pacemaker interpolation, long-term follow-up, and 3.5% of so-called reducator ablation. Important, why we use normothermic CPB? Because we would like to control on restoration different rhythm after each type of procedure. You will see if you isolate right and left pulmonary vein, you have only 5% of restoration sinus rhythm in patients with extended persistent atrial fibrillation. If you do left side procedure, only 46. During the operation, in 86, if you have bilateral approach. This is our recommendation for each patient with extended after 2 period of time, you should do the bilateral approach. In Vishnevsky Institute, we use 6 or 7 port two-way access and conduct 10-fold bipolar ablation of PV ostium on left atrium posterior wall isolation for the long-standing persistent atrial fibrillation treatment. I fully agree with Jimmy Cox's concept for hybrid MACE procedure. We should start with initial thoracoscopic surgery, retractile appendage amputation, and follow up after 3-4 months. If necessary, we can perform a catheter ablation and for left atrial line and right inferior line. So finally, core issue of successful interventional and surgical treatment of persistent AFib is persistent AFib have so-called atrial arteriopathy that eventually will progress. Catheter ablation doesn't yet cause transmural lineal injuries in 50 or 60% of cases, and fat and fibrous tissue prevent getting transmural injury in 20% of cases when it's cryo and radiofrequency ablation, and left atrium volume, arrhythmia duration, concomitant pathology determine arrhythmia relapse in postoperative period. So today we have hybrid team including 5 or 6 physicians. In future, it should be only one in one hand. What arrhythmias should do in the future? Electrophysiology, thoracoscopic surgery, arrhythmia surgery, and a patient can trust this type of physician in future. Thank you very much for your attention.
Thank you very much, Dr. Revashvili. You're really one of the pioneers, and the big advantage is that you're a team in one person. So you're EP and cardiac surgeon in one person. You do have all the knowledge which a surgeon needs to perform correct ablation. I'm really looking forward at the end of the whole session of our discussion. And now our next presentation is titled The Role of the Surgeon in Non-AFib Arrhythmia Ablation. And this is to be presented by Dr. Marc Lamer. He's also a good friend and pioneer for AF surgery, and he's from Brussels, Belgium. And Marc, take it away.
Dear colleagues, it is my pleasure to share with you the role of the surgeon in non-AFib arrhythmia ablations. My disclosures. It's important to understand that in these kind of procedures, the surgery is less based upon an anatomical approach, with, for example, the creation of linear lesions like we would do in a AFib ablation, but mostly based upon a EP mapping of the substrate of the arrhythmia and a guided ablation. These are the different arrhythmias that we treat nowadays in our center: IST POTS, PVC, VT ablation, Brugada, and ARVC. And on this slide, you can see the tools we are using for the epicardial ablation, either surgical or coming from the EP lab. In 2016, we started our experience with inappropriate sinus node tachycardia and POTS. This is the publication of the first 50 patients. Important, all patients failed pharmacological treatment. It's a right-sided approach, 3 5-mm ports combined in a single step with a transfemoral catheter approach. This is the lesions that we create. We isolate the superior caval vein, inferior caval vein, crista terminalis from the sinus node area. And on the left side of the screen, you can see the map post-ablation. An example of a isolation of the superior caval vein, you can see the bipolar clamp on the SVC, thereby isolating the SVC from the sinus node area. The results after 2 years, we have a reduction of more than 25% of the heart rate, which is an endpoint of the procedure, and in post-PC patients, there is no syncope observed. An example of a change of the ECG during the ablation, you can see sinus node tachycardia on the left side of the screen going into a slower sinus rate. The second procedure we perform is the RVOT ablation with, in most of the patients, epicardial ICD implantation in patients with Brugada syndrome. We published our first 36 patients. The procedure performed by a left thoracoscopic approach, 75% have a concomitant subcostal ICD implantation. Procedure time for the ablation without implantation is 42 minutes, ablation time 12 minutes. Most important complication is pericarditis, which we see often in these epicardial arrhythmia patients. Important to understand is that after the procedure, Asmin test is performed and in only 1 patient remained positive. Here you see the setup of the procedure in the hybrid room where the EP and the surgeon are working together. And here you see the mapping catheter on the epicardial surface and the surface EGM we can also use to study the arrhythmogenic zone. After having defined the area of interest, we perform an ablation with an epicardial surgical bipolar linear tool, and if needed, complete it with a epicardial RF application by a 4mm tip catheter. These are the results. Interesting to see that there was only 2 patients with VT recurrence, which were already at the beginning known as more sick patients. Concomitant implantation, an example, you can see here the position of the dual coil ICD lead and the left ventricular lead for pacing sensing. We also perform this in young patients. This is an example of a 3-year-old child which was transferred to a center after having stayed 2 months in an ICU for incessant VT-VF. Hybrid VT ablation, also a very important topic for epicardial VT. This is an example of an EGM of one of these patients where we induce the VT and then can see the site of where the VT is starting, which is shown by the arrows. 34 patients we performed between 2015 and 2020. I think what is important is that there are recurrences in this VT population, which most patients already had prior EP procedures. We are thinking of perhaps putting some of these patients on bypass in order to improve transmorality of the lesions, but this still has to be studied. ARVC, I think a very interesting possibility. Instead of opening the patient and putting him on bypass through a left thoracoscopy as with a VT ablation, in fact we perform what we call a Brussels waffle technique. We first map the right ventricle and then we perform a cryoablation of the right ventricle, taking into regard of course the coronary arteries. And here you see the cryoprobe lying on the anterior wall of the right ventricle, and we will just make linear lesions in this direction and then cross them by linear lesions in the other direction, like we would see in a Brussels waffle. That's why we came with the name. And interestingly, the follow-up of these patients, none of these patients recurred their arrhythmia. So in conclusion, I think we have now several possible non-AFib arrhythmias which can be treated by a hybrid epicardial surgical approach. And this is a team, and I do believe that the surgeon can play a central role in this arrhythmia team. Thank you for your attention.
Thank you, Dr. Lemaire. Our next presentation is an abstract presentation that is titled Surgical Treatment of Long-Standing Persistent Atrial Fibrillation, MACE versus Thoracoscopic Ablation, to be presented by Dr. Vadim Popov from Shniensky Institute in Moscow and the Russian Federation. Dr. Popov, please take it away.
Ladies and gentlemen, thank you for the opportunity to present of our study. I have no conflicts of interest to declare. In terms of treatment of long-standing persistent atrial fibrillation, some of randomized trials have been demonstrated benefits of thoracoscopic surgical approach or catheter option. Otherwise, latest randomized clinical trials CASA-F revealed similar results of catheter ablation versus thoracoscopic in the treatment of long-standing persistent atrial fibrillation. MACE procedure can be considered as the gold standard of long-standing AF surgical treatment. This operation continues to demonstrate the best in hospital as well as long-term results. However, open heart surgery with CPB is associated with relatively higher invasiveness. That is why it's very important to compare in hospital and midterms results of MACE and thoracoscopic surgical ablation for long-standing persistent AF. We conducted a prospective non-randomized study with two groups included thoracoscopic ablation, 90 patients, and MACE procedure, 134 patients. In hospital outcomes, as well as follow-up to 3, 6, 12 months, respectively, after the surgery, were evaluated. Primary endpoints were freedom from AF and MACE, secondary endpoints, operation time, ablation time, ICU stay, complication, and pacemaker implantation rate. Here is baseline characteristic, including AF duration, number of previous catheter ablation, and presence of perioperative antiarrhythmic therapy. None of these variables has statistical difference. Here is some echocardiographic and CT data. There were no statistical difference in these parameters, including left atrial size. Modified Cox-MACE procedure had been carried out on beating heart with CPB. This technique included all standard MACE lesions, some of them set up through purse strings. The mandatory points are control of the sinus rhythm, restoration, check of the exit block, and left atrial appendage ligation. This technique was proposed by Professor Amiran Revashvili. Our thoracoscopic technique included box lesion set, right and left pulmonary vein isolation, roof and inferior line, exit block testing, left atrial appendage exclusion with bilateral approach. Evaluation of procedural data had been demonstrated statistically low operation time, ablation time, and spontaneous sinus rhythm recovery in thoracoscopic group comparing to MACE-5. Thoracoscopic group has significantly less drainage blood loss, less pleural effusion, and AF recurrency. Pacemaker implantation occurred less often in TSA, however, is not statistically significant. In thoracoscopic group was significantly less ICU stay and in hospital stay as well. Freedom from AF in MACE-5 group in 12 months was 92%. In TSA group, 82%. During these 3 months, 6% of patients underwent catheter ablation after MACE-5 versus 13.3% after TSA. Sinus rhythm was restored after this procedure in 100% cases in MACE-5 group and in 33% in thoracoscopic group. Main advantages of this study are comparison of these two surgical options, efficacy of left-standing atrial fibrillation, and statistically comparable groups. Main limitation, absence of randomization and non-continuous rhythm assessment. To conclude, despite Cox-Maze procedure still being the most effective treatment option for long-standing AF, thoracoscopic surgical ablation provides comparable midterm results with less postoperative adverse effects. Thoracoscopic surgical ablation can be a very promising technology, especially in hybrid manner. Thank you for the attention.
Yeah, thank you very much, Dr. Popov. We would now like to open this up to the attendees for discussion. Reminder to all of our attendees, please be sure you are typing your questions into the Q&A box on the right of your screen. Since now I do not have seen any questions. Niv, do you have a question for all of them now?
I want to address a question, and please, Mark and maybe Dr. Butcher, just a quick answer. There is a big difference between applying a lesion and having a consistent lesion. And as we know, unipolar devices are very limited where being done on a full and beating heart. So that resistance to use heart-lung machine in order to improve the ablation depth and consistency seems in this day and age a bit old school because of the new data, especially the one coming from UCSF on the lack of impact of heart-lung machine on anything related to cognitive function. So Mark, what would be the future solution? And from the EP standpoint, what do you really see long-standing, with those epicardial ablation with regard to consistency?
Well, thank you for your question, Niv. So I think what is very important is that we now have these bipolar clamps, or now since a couple of years, 10 years, and we do consistently, certainly if you do a single-step hybrid approach, that these clamps are capable of giving you a transmural lesion. That is important. If you use a bipolar but unidirectional device or a monopolar device, it is much, let's say, more difficult to achieve these lesions, and you can see that you need many more applications. So it's a question of, with a bipolar clamp, with a couple of applications, you will have a transmural lesion. With the non-bipolar clamping systems, you will need many more applications. And that is, I think, the reason why we believe that a hybrid approach in a single step or dual step is important to complete these potentially non-transmural lesions in order to increase your success rate.
Very good. I would like to ask a question to Michael Zembala.
Yes.
Michael?
Yes.
Yeah, I would like. Yeah, I'm quite impressed of your technique, and I feel convinced that this is really one part of the future, because we bring both together, because what you do is incomplete, and we are depending on EPs, and you need to be a team together. But my question is it possible to simplify it a bit more, that it's reproducible for everybody? So I've seen you open the left chest. It was an excellent closure, echo-guided of the left atrial appendage. And then you have the subsulfate approach. On the one hand, is it possible to have an isolated subsulfate approach at the same time, maybe a LARIA procedure? And on the other hand, is it possible to have just a left-sided chest approach through which you can treat left atrial appendage and do the ablation of the posterior wall with a convergent system in one time? So the question is, does it make sense to simplify your procedure to an isolated subsulfate or isolated left-sided?
yes, we've tried that, and I know that companies are working on the modification of the system. So far, because of the steep angle, it was not possible to use one axis, meaning either subxiphoid or transabdominal. But I know that it is in the pipeline and probably will be doable. Now, the AtriCure has just purchased the Lariat, so I think it was also because of that approach. And with Lariat, it could be possible. But in our setting, we usually performed, like, I would say 95% of all the cases without left atrial appendage closure, and would do it later on if necessary. But that was not our standard approach. So we did not combine these two procedures, only in very selected patients.
Okay, thank you very much for your answer.
Thank you. But as you mentioned, we based our success on mutual trust, as our lesions are 100% incomplete.
Yeah, that's true.
There is one question. Yeah, there is one question for Mark specifically, which is, do you find that you have to take the LAA routinely? It is part of the LV Summit approach as well. So I don't understand. It's probably related to VT ablation, but maybe comment in general in light of Dr. Zambella's answer. Mark, in what percent of your patients you take the LA appendage in AF surgery and maybe also in VT ablation?
Well, thank you for your question. I believe that in AF surgery, certainly for those patients who are referred to this program, in our center and the referrals we get, one of the main reasons for referral is that the cardiologist and EP think there is an advantage of closing the appendage, which is typically not done during the same procedure when they perform a percutaneous approach. And so I have to admit that for us it's 99%, not to say 100%. In VT ablation, of course, it depends upon the patient. Some of the patients with VT have AF, paroxysmal. In these patients, we tend to treat both, let's say, arrhythmias at the same time, and therefore also will exclude the left atrial appendage. But typically we will look at the CHA2DS score. LV Summit, I think that's a very interesting procedure. That is certainly an area where the epicardial approach with visualization through a left thoracoscopy can make the difference, because if you do a side approach, which is something EPs could try, you don't have any straight realization of the coronary arteries, and therefore certainly in the LV Summit there's a major risk for damage. But it's not only that, it's also the amount of fat. It's an area of an abundance of epicardial fat, and if you have a good contact force, and we typically use the 4 millimeter RF irrigated catheter from the EP lab, if you have a proper contact force, you really can melt the fat. So you melt the fat on top of the arrhythmogenic zone, and therefore you get transmural lesions.
Okay, I think that is all the time we have left for the group discussion. I really want to thank all of you for the effort, the presenters, the studio, and Dr. Dole and I are now going to turn the screen over to Drs. Balki, Cerny, and Naifong, who will moderate the second half of this session. We did it so can you initiate a robotic surgery program all around the world. Drs. Balki, Naifong, and Cerny, please take it away. Thank you. Bye-bye.
Bye. Bye-bye.
Thank you, Dr. Ad and Dr. Dole. I'm Wiley Naifong, and I'm honored to be joined today by Dr. Cerny and Dr. Balki. For the sake of time, we're going to get right into the next segment of the session, so we have some time for discussion. So Dr. Cerny, can you let the viewers know what we have in store for them?
Certainly, thank you. This segment will feature 2 invited lectures, then 4 abstract presentations, followed by a group discussion. As a reminder to attendees, we encourage your participation. Please use the question answer box on the right of your screen to type in questions as we go along. Dr. Balki, would you do the honor of introducing our first presentation, please?
Absolutely. Thank you, Dr. Cerny, and thanks to you and Wiley, Dr. Naifong, for co-moderating this session. This session came out as a result of many abstracts that were submitted to the program this year from programs early in their experience. And so we thought we would put some of them together and demonstrate the increasing adoption of robotic cardiac surgery around the world. Both Dr. Cerny and Dr. Naifong have had a very strong influence in this regard and have helped many of these programs in their development. We're going to start off the discussion with 2 non-nascent programs. First is Dr. Modi, who's an experienced robotic surgeon, has done a couple of fellowships, is going to tell us about the challenges in starting a robotic cardiac program in Europe, how I did it within the National Health Care Service, and then my junior partner, Dr. Tor Grossa, will speak about young surgeons and cardiac robotics. So to start off, Paul, take it away.
I'd like to thank the Society for giving me the opportunity to talk about the challenges in starting a robotic cardiac surgery program in Europe and how I did it within the United Kingdom's National Healthcare Service. I've got no disclosures. Things we're going to consider, well, first of all, you've got to be convinced there's a benefit to robotic surgery. As Doug Murphy once said to me, you've got to want to do it because the journey can be quite challenging. Secondly, we're going to look at training and how to train in it. Thirdly, cost considerations, and finally, patient selection. And at the end, I'll show you a video that'll hopefully convince you of the benefit of robotic surgery. Well, if you ask 100 patients how would they want their mitral valve repaired or their coronary surgery done, would they want a stenotomy, or would they want a robotic mitral or robot-assisted mid-cab, all would say the 2 robotic options. How do you train in it then? Well, I think the most important thing is to do a 12-month high-volume fellowship, and I was lucky enough to do Dr. Chitwood's fellowship, where we did between 4 and 8 robotic and mini mitral repairs per week, and that really helps you through the learning curve of both robotic mitral valve repair, but also the setup of minimally invasive mitral valve surgery. This picture in the top right corner is one Dr. Chitwood used to show. And introducing robotic surgery is akin to climbing Everest, where the summit of Everest is robotic surgery and base camp 1 is stenotomy. We all know we can't go from base camp 1 to the peak. We've got to acclimatize at the mini mitral stage. Intuitive surgery will have a very didactic training pathway, and that should be followed. And train with the whole team. So take the anaesthetist, scrub, circulating nurses, and perfusion away to visit various institutions. And we visited Dr. Murphy, Dr. Sutter, and Sam Balki in Chicago. And each member of the team paired off with their counterparts in the OR and shadowed them for a few days. And then you just replicate that when you get back home. What about cost? Well, clearly within the context of a healthcare system with finite resources, cost is a major limiting factor, but it depends on what the vision of your institution is, whether you want to be innovators or laggards. A robust business case with involvement of the chief financial officer is absolutely vital. And one way of getting the cost of the robotic operations down is to use the robots more and more. So if you can share it with thoracic surgery, urology, GI surgery, then the cost per case becomes less. And finally, charitable donations, certainly for us, were very important. What about patient selection? Well, this is threefold. First of all, we say to every patient, the only important thing is keeping you safe. The most important thing is keeping you safe. Number 2, we aim for perfection in valve repair, and hopefully this is a repair that will last a lifetime. And number 3, do number 1 and 2 in the least invasive way possible. And I think if you have that in your mind all the time when you're adopting robotic surgery, you can't go wrong. If the repair is too difficult, just undock the robot, extend the incision, do it as a mini mitral. Most successful robotic programs have surgeons who've done several hundred mini mitral before they adopt robotics. Choose easy valves to repair, posterior foot prolapse in patients with no aortic regurgitation or MAC, good biventricular function. Always have a proctor when you first start off and involve intuitive surgical in that. And get through your other learning curves first, so mitral repair learning curve, the mini mitral setup, intraclude use, and if you're doing robot coronary surgery, be an off-pump surgeon and have done non-robotic mid-cap, and keep the team constant at least for the first 20 cases. Okay, let's have a look at a video of a patient undergoing robotic surgery.
Dr. Modi's carried out thousands of operations, but this is a week of firsts even for him.
You all set? Yeah, I think so. Yeah, how are you doing with it?
Liverpool Heart and Chest Hospital has taken delivery of its very own surgical robot. Owen's been hand-selected to be one of the first patients to take part in the programme. He needs his mitral heart valve repairing.
A bit anxious about it because it hasn't been done really in Britain and things. So yeah, a little bit anxious, but yeah, no, I know I'm in good hands.
After weeks of training in America and months of practice back here, it's time for Dr. Modi to see the Da Vinci robot in action in his own operating theatre, under the watchful eye of his American proctor, the world lead in robotic heart surgery.
It's the best prepared team that I've had the opportunity to work with. I've been working towards this week for the last 10 years.
So how does it work? It's not a true robot, it still needs a surgeon. They sit and operate it using hand and foot controls, which accurately mimic every movement the surgeon makes while removing any tremors. They send signals to the arms, then everything is relayed back here in HD and highly magnified.
With the robotics, it's just like building a ship in a bottle. It's just 5 little holes, and you can work inside the heart very meticulously.
It's hoped the benefits to patients like Owen will be massive. Smaller incisions means less pain, less blood loss, less infection and less complications, leading to a shorter stay in hospital and a much faster recovery time.
Going back 6 years, patients here would have had conventional surgery where we open the front of the chest and it takes them 3 months to recover from it. Now, patients are home in 3 days, they have minimal pain and they're back at work in 3 weeks.
But there are drawbacks. Surgery can take longer, and some research suggests the final outcome is no different to traditional surgery. And with little competition in the market, they're really expensive to buy and maintain, although it's hoped here the robot will eventually pay for itself. So is the cost worth the benefit? Well, just ask Owen. Here he is 48 hours after open heart surgery.
The thought that I'm going home today is just phenomenal.
2 days later, I'm taking him home.
Yeah.
So amazing.
Nothing to stop us now. There's no lingering doubt or anything.
Yeah.
It's hoped eventually this robotic surgery will be routinely offered to every patient here. Katie Waldman, BBC North West Tonight, Liverpool.
There he is 4 days after surgery, up a hill in North Wales where he lives. Quite remarkable. There's a speed of recovery, 2 days in hospital, they would never saw with mini mitral surgery. Thank you for your attention.
Thank you, Paul. Thank you, Dr. Modi. It was obvious to me when Paul was with us for a year that there was no doubt he was going to be successful. He's so dedicated, kind of went about things in all the right ways and worked for years to finally see his successes. So congratulations. And great socks, by the way. That's the one thing on robot days, you have to make sure you wear nice socks. So now we're going to turn it over to some of our even younger cardiac surgeons. As you know, all of those, sorry, Sam, I have to say all of us older cardiac robotic surgeons now, should be helping to turn things over. So our next presentation is titled Young Surgeons and Robots, Is It a Good Idea? And Gianluca Torregrossi from the University of Chicago is going to speak to us, and the screen is yours.
I want to thank the Society of Minimal Invasive Cardiac Surgery for this invitation to speak on young surgeon and robots. Is it a good idea? I do not have any financial disclosure. 30 years after the seminal paper of Alain Carpentier on mitral valve surgery, Stephen Bowling showed that the chance to have a mitral valve repair if you had degenerative mitral valve disease were 50% if you were a patient in the United States. That means that applying new surgical techniques in cardiac surgery takes a long time to be reproducible for most of the surgeons. Similarly, in the early 2000s, in the history of coronary artery bypass grafting, we were about to celebrate the funeral, the death of CABG surgery. 21 years later, bypass surgery has never been as healthy as now, with a very proven solid data about the long-term benefit of what we do and a precise role of percutaneous intervention rather than bypass surgery. So in the current era in which surgeons, industry, cardiologists, and almost patients are all admiring this new transcatheter technology coming into the market, I'm deciding to create a niche into robotic cardiac surgery. Does that make sense? It does, and it does mostly for three main reasons. First, we all as surgeons stand on the top of a hill built by the last 40 years of safe record results of reproducible and very high quality long-term results of surgeries. Papers like Tyron David's one on long-term results of mitral valve repair, the value of a left internal thoracic artery to the LAD or a bilateral internal thoracic artery to the best left coronary targets are very difficult arguments to shy away in a discussion. It doesn't matter how many transcatheter valve you can place, a mitral valve repair has performed surgically, has a proven solid data. The second is that the minimally invasive cardiac surgery is the new gold standard in cardiac surgery. And among the different techniques of minimally invasive, robotic is the most versatile platform. What I mean by that? Leipzig has showed that if you want to train yourself in minimally invasive mitral valve surgery done through a mini thoracotomy, you need between 75 and 125 cases to be proficient. And you spend all of this time to train yourself and learn one technique to treat one pathology. Robotic instead is more than that. Robotic is a tool. You learn how to use a tool and you adapt in very different scenarios. The robotic platform can be used in mitral valve surgery, can be used to perform a solo cryomace procedure in treating atrial fibrillation, can be used to perform a myocardial bridge for the management of the left atrial appendage in cases of constrictive pericarditis, and my favorite type of surgery to perform bilateral internal thoracic artery bypass grafting at TCAP with distal anastomosis performed robotically, and you can reach every target of the left or right coronary system and offer the best type of graft to patients. And this shifting paradigm has been summarized in one of the papers that our group, our center, has published recently on innovation. With a robotic platform, we have been able also to approach aortic valve disease, redo coronary bypass grafting, redo valve surgery, or double valve disease. And this is the main reason that brought me into approaching robotic platform, bilateral internal thoracic artery, and there is a grafting, TCAB, and there is the possibility to democratize the use of beta on all comers, independently from their HbA1c, the level of obesity, female patients that you will never offer beta grafting through a sternotomy. This is a very reproducible, safe, precise type of surgery. And differently than any mixed approach for coronary bypass surgery or beta bypass through mid-CABG, this is applicable to all comers, to every patient. The selection criteria to include in TCAP beta are extremely, extremely broadened. The reality, though, is that we are shifting from the idea of mix versus robotic. Who is better? This is an argument that belongs to the 90s. The future, in fact, is that we are all going into the same direction, where mix through endoscopic nowadays is going to the same direction of robotics with new robotic platform. And if we embrace and integrate transcatheter technology, we can depict what will be surgery 5 or 10 years from now. So the future of robotic cardiac surgery is bright. Robotic offers a platform for minimally invasive cardiac surgery when we can integrate new technologies, AI technologies to define and highly define anatomical structure. We can even teach a robotic how to take down a left internal thoracic artery automatically. If I can teach a car to drive in the traffic of Naples. And new robotic platforms are entering in the market. If the future is bright, the current present, though, is painful for young cardiac surgeon interested in robotic. And mostly it's because several industries are not yet supporting or have decreased the support towards these specialties. So we need a new generation of young surgeons interested in robotic cardiac. Is it a good idea? Still, in the current present, I say yes. You learn a very versatile platform that can help you approach different pathology. And beta TCAP is the future of surgical coronary revascularization. Thank you so much for your attention, and I'm available for any further question.
Thank you, Gianluca, for an excellent presentation. I totally agree that the future of robotic cardiac surgery is bright, and we, of course, need the help of young cardiac surgeons who should be involved in pushing the industry. I really agree. Let's move to our next presentation, which is titled Learning Curve in Robot-Assisted Mitral Valve Repair for the First 100 Cases, to be presented by Daiki Yoshiyama of the University of Chiba Nishi General Hospital in Masudo, Japan. Dr. Yoshiyama, the screen is yours.
In this video, we will present this clinical research of the learning curve analysis of the robotic-assisted mitral valve repair. Regarding the scale of the robot-assisted surgery, there were few reports of objective analysis. How many cases are needed for achieving stable phase of the critical surgery? Therefore, we analyzed the learning curve of robot-assisted mitral valve repair, RMVR, using our 100 consecutive experience. The initial 100 cases of RMVR between 2018 and 2021 were retrospectively analyzed. The cases were divided into two groups for this comparison. The first 50 cases were Group E, and the second half of cases were Group L. According to the case experience, how many cases are necessary for achieving stable phase was analyzed using QSUM study. In preoperative clinical characteristics, the only NIHA had a significant difference between two groups. This video shows result of intraoperation characteristics. Regarding this table, there was significant difference in the operation time, the CPB time, and the cramping time between two groups. In the short-term clinical outcome, there was significant difference in the ICU stay and the drug transfusion. This graph illustrates the change of operation time with surgical experience. The vertical axis represents the operation time, whereas the horizontal axis shows the surgical case loads. According to this, there was a shorter trend in operation time with more case loads. Based on the QSUM analysis, we found that at least 75 cases were required for reaching the satisfactory level. The graph demonstrates the relationship between CPB time and the number of surgical cases. This trend is similar to the former slide. Similarly, this QSUM analysis reveals surgeon's performance could reach the acceptable level at the 75 cases. In this video, the cramp time is plotted. The same trend can be seen in this graph. The satisfactory level for the cramp time was also achieved at 75 cases. As in other studies, surgical experience is important to shorten operating time. In Q-sum operative CPB clamping time least acceptable level at 75 cases in RAVR. In our study, first 50 cases required significantly long operation. Until you get used to operation, careful operation planning such as case selection and standardization is considered important. Thank you for attention.
Thank you very much, Dr. Yoshiyama. Great presentation. Our next presentation in this session is Initial Experience in Robotic Cardiac Surgery, to be presented by Elena Sandoval of Hospital Clinic in Barcelona, Spain. Please, Dr. Sandoval.
Good afternoon. My name is Elena Sandoval from Hospital Clinic in Barcelona, and I'm going to present our initial experience in robotic cardiac surgery. None of the authors has anything to disclose. Robotic cardiac surgery has slowly expanded, especially in Europe, mostly due to its perceived technical complexity. Our group has more than 20 years of experience in thoracoscopic surgery and has recently started a robotic program. Since the beginning of the program in December 2019, we have performed 58 robotic cases. Most of them have been mitral repairs, including anterior, posterior, and bileaflet programs, but we have also performed mitral replacements, ASD closure with a concomitant tricuspid repair in one case, coronary revascularizations, and an aortic tumor resection. All cases could be completed robotically with a 100% mitral repair rate. Most patients were extubated in the OR with a median ventilation time of 0 hours. Median ICU and hospital length of stay were 1 and 5 days respectively, and we only experienced one in-hospital death in an emergent case with no reinterventions during follow-up. This slide summarizes the evolution of the ischemic time that we can see it was pretty elevated at the beginning of the program, but that has gradually been reduced, being now consistently between 50 and 80 minutes. So in conclusion, we can say that a wide range of cardiac procedures can be successfully performed with a robotic platform, that there's a learning curve that we believe it can be softened with a previous experience in thoracoscopic surgery, and that our initial results are good with a short ventilation and length of stay time. Thank you.
Thank you, Dr. Sandoval. Very interesting, and I think many of us have shared your experience. Our next presentation is titled Establishment of Robotic Cardiac Surgery, the First 150 Cases, presented by Dr. Huther and her colleagues from Stuttgart in Germany.
Hello, my name is Franziska Hüter, and I'm working at the Department of Cardiac and Vascular Surgery at the Robotic Hospital in Stuttgart, Germany. Today I'm going to talk to you about the establishment of a robotic cardiac program, the learning curve, and the results of the first 150 patients. No disclosures. The Da Vinci system for minimal invasive cardiac surgery is well established in the USA, but not yet in Europe. The costs of investment are quite high, as well as it's technically challenging. We were interested in the safety and in the learning curve. Between July 2019 and November 2020, we operated on 150 robotic cases supported by the Da Vinci Xi system. The cases were performed by 2 surgeons, which were supported by a defined OR team out of 3 table assistants and 3 nurses. Here you can see the surgeon in front of the Da Vinci, as well as the table assistant and the scrub nurse. We performed 83 mitral valve reconstructions, 34 op-cap procedures, 23 mid-cap procedures, 3 AC patch closures, 6 myxoma resections, 2 tricuspid valve reconstructions, and 1 MACE 4 operation. On the right side, you can see the accompanying procedures during mitral valve reconstruction. Here's a table with the overall results. The mid-cap and op-cap patients had a mean ICU stay of 16 to 17 hours and a mean hospital stay of 5 to 6 days. The mitral valve reconstruction cases had a mean ICU stay of 22 hours and a mean hospital stay of 6 days. The skin-to-skin time could be significantly reduced in mid-cap and up-cap cases. Between the first and 5 last patients, in mid-cap, the time could be reduced of 30%, and in up-cap procedures, the time could be reduced up to 44%. The same could be seen in the mitral valve cases. The cross-clamp time could be reduced by 27%, ECC time by 24%, and skin-to-skin time by 26%. Complications in mitral valve surgery were, for example, bleeding from the thoracic wall or fat tissue due to the less overview. In coronary surgery, we had, for example, a dissection of the bypass graft, as well as the need of the revision of anastomosis. In the end, you can say that the Da Vinci system allows safe operations and a stiff learning curve even during the initial establishment phase. Thank you very much for your attention.
Thank you, Dr. Viter, for an excellent presentation. I'm really glad that your center is doing so well, and my congratulations. You did a great work, and your results are encouraging for new European centers which are considering starting the robotic program, and it's really time to start now. Our next presentation is the final presentation within this session, so please be typing your questions into the question and answer box on the right hand of your screen. And let's move to the last presentation in this session, which is titled Robotic Assisted Hybrid Coronary Artery Revasculaization Program Establishment and Early Experience in the Middle East, to be presented by Uthman Al-Uthman of King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. Dr. Al-Uthman, the screen is yours.
Good day, everyone. I would like to thank the scientific committee for allowing us to present this work titled the Robotic Assisted Hybrid Coronary Revasc Program Establishment and the Early Experience in the Middle East. No disclosures. Hybrid coronary revasc was introduced in the late 90s, which considered a revolutionary strategy in coronary artery bypass graft. The invasiveness of this procedure has been dramatically reduced with excellent short and long-term results. Quicker return to baseline activity and productive life for all of our patients. Establishment of robotic hybrid program includes multiple stakeholders. First step is to create the business model and convincing the higher management, allocation of the budget, and explain the risk and benefits for the program. Clinical pathway meeting with the pertinent medical personnel, including cardiothoracic surgeons, perfusionists, anesthesiologists, OR-tech, interventional cardiologists, and clinical engineers. Online and on-site training was obtained for all the team members, adherent to the guideline and the recommendation from the manufacturer and other robotic programs. An instrument and accessory was handled by our supply chain. Moreover, there was a comprehensive hands-on training for the all team members. At this stage, we reached the clinical independence and we start our cases. There were 78 patients who underwent robotic hybrid approach between 2018 and 2020. This is our inclusion criteria and exclusion criteria. And this the algorithm showed that all patients, all comers with a stable ischemic heart disease or acute coronary syndrome go through this, and before home, before discharge, there will be a complete revascularization early check. Our usual operative conducts, including robotic single or bilateral mammary harvest through the same port, then anterior mini thoracotomy for off-pump hand-sewn anastomosis with satisfied end result and small scars for all patients. This is the baseline characteristics. Majority of the patient is male, 98%, and PCI to the RCA was 28 patients. PCI to the RCA and the circumflex at the same time was 22 patients. Lima patency was 100%, and average operative time is 3.8. There was no hospital mortality. The mean hospital stay was 5 days, which include the PCI stay. Conclusion, establishment of robotic hybrid program is feasible with the great potential. It will merge the long-term benefit of Lima to LAD and less invasive revasc strategy with the PCI to other coronary region. We noticed that the robotic hybrid program led to 20% increase in our annual referral to the cardiac surgery program. Thank you.
Thank you very much, Dr. Al-Uthman. Excellent presentation, excellent results. A little bit more near and dear to my heart because you're operating in my hometown of Jeddah, Saudi Arabia. So congratulations on robotic program in Jeddah. I think our moniker said Riyadh, but Dr. Al-Uthman is a thinking facial specialist in Jeddah. We have about 5 minutes for the discussion here, and we have a lot of great presentations from all over the world. And if we could just go through the young presenters of the abstracts, maybe backwards, start with Uthman, and then go to Francesca, and then Elena and Daiki. What do you think was the most challenging aspect of starting your robotic program? In just a couple of sentences, very quick, so we can get to some good discussion here.
Good day, all. Thank you, Prof. Balki. I believe that the hardest thing is to get the team from all aspects, from cardiology, cardiac surgery, have everybody on board for such innovative pathway and something new for everyone. Selecting the right cases, the right candidate for this kind of surgery. Other than that, I think it is a great experience for people who love to work in teamwork.
Francesca?
Hi, thank you very much. I would say the same thing as my colleague before, that most of the work was getting all the team together and getting everyone in one boat and having everyone with us, which was the most difficult thing, but in the end, the most important thing for the patient.
Elena?
I agree with my colleagues. Getting the whole team on the same page at the same time was the key thing in shorter times.
And Daiki?
Yeah, I'm saying thing. So it's important to continue surgery with the constant team. And patient important select a simple case such as lesion of the posterior leaflet, single lesion is important.
Wiley or Stefan, do you have any questions? We have some in the chat.
Yeah, I was going to say, I see kind of one in the chat, maybe Dr. Modi could address. It was, I believe, after your talk. And then with hearing Francisca about length of stay. So, Paul, you have a lot of experience did a lot of mini mitrals, videoscopic mitrals before your robotic cases. So do you have any comment about length of stay? Did your robotic patients going home, faster? I know in the United States, there's great incentive for us to get patients out of hospital, as soon as possible.
Thanks for that question, Wiley. We've looked at that as we looked at our first 50 cases. The length of stay for a robotic mitral was 2 days shorter than it was for a mini mitral. And we've done about 400, 450 mini mitrals before we adopted robotics. I mean, in part that was because it took us a long time to raise the money for the robot. I think as the video showed, it's a patient looking that well. When they filmed them the BBC filmed them in the hospital room 48 hours after his surgery. That's something we never saw discharge on day 2 with mini mitrals, and then up a hill on day 4. As I said, it's quite phenomenal, the difference. And in our own data, it's 2 days shorter. So the usual post-op stay while it's about 3 to 4 days. The median came out at 3.5 days.
Excellent. Gianluca, you gave an excellent presentation as usual and have a lot of historical touches to it, as is your style, which I've come to know and I'm very impressed by. There's a question from Dr. Subramanian here who says, any experience in robotic mitral repair with concomitant cabbage? And since you've kind of absorbed the experience of multi-spectrum robotic surgery, do you want to comment on that?
Thank you, Sam. I think you are the best person who should give a comment. I mean, you are I think one of the very few, or the only one, who can do a TCAB concomitant mitral valve repair. We have done together with the team, and we always highlight the team because I think that's the most important part, as we have heard from everyone here who is introducing themselves into the robotic approach. But that's, again, you push the envelope, Sam, to a level that is opening the road, it's paving the way to the next generation of surgeons to see what is feasible with the robotic platform. And we are looking forward to receive even more technology that can be integrated together to make more feasible to cut the learning curve and making easier to adopt this type of techniques. At the end, ultimately, is always benefit of patients. Patients go home earlier. Patients receive best level of care of surgery in the same high quality that you have done through a sternotomy, or probably even a better or superior, because you are increasing your view and your chance to perform it.
I think this session, if anything, demonstrates the fact that robotic heart surgery is not a foregone conclusion. It is definitely on the rise, and the different accents, the different locations and geographies represented in this session speaks to the health of what we have as robotic heart. I hope that industry is watching and they will be able to take this as a message that that they need to support us. So I'm getting texted from the organizers that we've gone overboard. Wiley, do you want to make some final comments?
Well, no, I mean, it looks like we're out of time for discussion. So I'd like to thank all of the presenters again, and my co-moderators, and thank you all at home for tuning in. We're going to hand it back over to the live audio host at this time. He'll be with you in just a few moments. Goodbye.
Thank you.
Bye.
So another lively start to the day at ISMICS here on our third day. We completed our master sessions in thoracic surgery. The first session was all about the operating room of the future. We had really outstanding talks. Dr. Kelvin Lau from the UK really shared his hybrid room and how he utilizes it for diagnostic and localization purposes, combining the cone beam CT scanner with the navigational bronchoscopic platform that they have. And then also Dr. Calvin Ng from Hong Kong also shared really their system, which also takes endoscopy to a new level for localization, but also for endoscopic ablation of lung cancer. And let me just say that these are thoracic surgeons leading the way in thoracic endoscopy, and I'm really proud of the programs they have. In the following session, really outside the operating room, these were really critical talks that I really encourage both the cardiac and the thoracic audience to log in and watch. They'll be saved online and on CTSNet. But one in particular, Dr. Benor, discussed the gender gap in cardiothoracic surgery and what we need, all of us need to do to really do away with this. Mara Antonov from MD Anderson, who both moderated and gave an excellent talk on how to build your social media presence, and Usman Ahmad from Cleveland Clinic gave a really interesting talk on IP development. Many of us have great ideas and we don't really know how to develop them, and really these were great videos that I encourage us all, including efficiency talk and building a program from scratch. Dr. Lazaro from Lenox Hill, how to build your tracheobronchomalacia program. Dr. Delusky on how to be more efficient in the operating room. Really excellent. Sam, how was cardiac today?
Thanks, Abbas. Cardiac was excellent. We had a wonderful morning session. I just got back from moderating our round the world new robotic program presentations with great abstracts from all over the world, and it speaks really to the rise in robotic heart surgery with a lot of younger surgeons adopting the technology. There was a session on atrial fibrillation. We had a couple of great live in the box presentations. Piotr, you want to talk about the AFib presentations? I think you were part of some of those. We saw some of your great handiwork.
Thank you. Yes, I think it was a very interesting morning in the US, afternoon. So a great session. So what I liked very much is, first of all, there was a focus on atrial fibrillation, but also on non-AFib arrhythmias. And secondly, just similarly also to Revasc topics, the many speakers emphasized the necessity of cooperation between cardiac surgeons and electrophysiologists, or generally cardiologists, and I think this is the future of further development in many parts of our branch. So I think it was extremely interesting. It was also very international. And I like also the speech from Professor Revishvili, who is at the same time cardiac surgeon and electrophysiologist, which also gives a very special perspective to what I have just said.
The part that I really found extremely very, you can say, reassuring about the young surgeons, how they're adopting the new technology, the robotics, and it's good to hear that we have definitely opportunities for further advancing this field.
One of the things that I always like to do when I go to a meeting, and this is a meeting that we have come to, is to take one or two things that I'm going to try to adopt when I get back home. And so there's two things that I learned just in today's sessions that I want to spend more time thinking about that I saw in the videos. One is and we talked about it I think in the session, one is the exposure of the diaphragmatic surface of the heart from an abdominal approach. So when doing a gastroepiploic bypass to, say, the PDA, the exposure that we saw from the convergent procedure really does show the back of that heart very, very well. And so that's something that I'm going to be thinking about from the technical aspect. And I'm very happy to see that our meeting is really, really strong in showing technique and you know, kind of teaching some of these minimally invasive approaches that we each have.
Yes, this was a very nice case from Zabrze, so congratulations. I fully agree. We had quite a few nice live-in-box presentations, and I assure you I also have noted down a few tricks that I have seen all over last 3 days, including today. So this is great.
So, Bob, do you want to take it from here?
Well, yes. We're going to have a bit of a change in the schedule. We're supposed to take a break, but because we're behind, we're not going to do that. But however, this is a time in the agenda that we would like to acknowledge our present president. Our president has basically provided great leadership in the last 2 years and has put us through some really unpredictable period of what was occurring in the world. So on behalf of the society, I would like to take this opportunity of acknowledging our president and appreciating him for the outstanding service that he's provided in leadership and overall the organization from the International Society of Minimally Invasive Cardiac Surgery. So as a token of our appreciation, Mr. President, I would like to hand you this gavel as a token and to remind you of the great appreciation that we've had for all the work you did.
Thank you very much, Bob. Maybe. Yes, thank you very much. Yeah, let's have another photo.
Congratulations.
I'll have it. Thank you very much. So, just very shortly, it's been really 2 unprecedented years, but not easy. But on the other hand, surrounded by such great people like you and all members of ISMICS, it made it much easier and I think we made it. And I think it's been really huge, the biggest honor in my life to be the president of ISMICS. And I'm very happy that ISMICS is now in good hands. And I wish you a good, fruitful presidency and a good annual meeting. Thank you. Thank you very much.
Thank you.
All right.
Thank you. Thank you.
Thank you. Thank you for that, Bob. That was great. Okay, so we are going to not take a break at this time, and we're just going to continue with our programming. We're going to move straight to the cardiac and thoracic tracks. We have the video session coming up on the cardiac side, and this is going to be moderated by Dr. Pavlan Atluri and Dr. Marek Deya, and that will be followed